liaison geriatrician, so I not only do ward work, but I also do 3 heart failure clinics a week. So I've been asked to speak today about heart failure, and yes, I know it's 101 in the elderly. I am going to come at this from an elderly perspective, but the majority of the patients you see with heart failure are elderly, so that's hopefully helpful. So I'm going to hopefully take you on a whistle-stop tour of heart failure. I'm going to try and explain to you what heart failure looks like in 2021, what treatments are available, which ones have evidence base in the over 75s, how to approach elderly heart failure patients that present acutely, how to deal with them on the wards with very specific scenarios, and some practical pointers re-management and about interpreting echocardiograms. Hopefully that's what you guys want. If not, tell me now. Good, great, that's what we wanted, good. So you were probably taught at some point, and I know I was taught this as a medical student, that there's right and left-sided heart failure. Doesn't really exist, sorry guys. Then you were probably taught this, which is systolic and diastolic dysfunction, except no one really told you what diastolic dysfunction was, what the criteria were for it. It was kind of this spurious diagnosis and this term that got bandied around, but no one really knew what it meant, how you treated it, all these kinds of things. So it wasn't really well defined. So it doesn't look like this in 2021 either. This is what heart failure looks like, and I know it looks complicated. So there's actually 4 different types, broadly speaking. The first one is heart failure with preserved ejection fraction. The second one is heart failure with reduced ejection fraction. The third one is with valve complications, so failing heart due to normally in the elderly population of mitral regurgitation, aortic stenosis and tricuspid regurgitation. And then you also get pulmonary hypertension. And the far and away most common cause of this is things like COPD, recurrent PEs in the lungs, kyphosis, especially of older women with osteoporotic fractures, ankylosing spondylitis, and also patients who are obese who have obstructive sleep apnea. This can occur in. I could actually have an entire talk on valves and secondary pulmonary hypertension, but actually I'm going to focus on the 2 most common, if that's all right by you, because these are the ones that by far and away you're going to see the most of, which is the top 2. Why are we fussing all about this, and why is there a geriatrician doing heart failure? Well, there's currently about 1 million people living with heart failure in the UK, and that's an underestimate by a lot. And it's going to increase. They think the number is going to quadruple in the next 7 years because we're really successful at treating people having MIs now, and actually they're living longer with ischemic heart disease. And to answer your question as why are geriatricians involved, actually the average age of diagnosis is 76 years old. So firmly within my remit. Not only that, it costs a lot of money. About 2% of the NHS budget is spent on heart failure patients, and 70% of that is from acute admission, so decompensated heart failure coming into the hospital. And not only that, when you put that in the context that 10% of all heart failure patients in the hospital will not survive that admission, we are talking about a very prevalent and high mortality condition. Not only that, the elderly patients have worse outcomes, they have more complex treatment pathways, and often they're undertreated because we're frightened of side effects. Not only that, there's huge variation in practice on how we treat them, and actually there's only one trust in the UK that all heart failure goes under cardiology, and it's not Sheffield Teaching Hospitals, it's Guy's and St Thomas in London. And actually most heart failure in STH is actually treated by endocrinologists, and that's actually an archaic agreement more than actually anything to do with heart failure. So the other thing is, if you present to a district general, you may be under an acute medic, a diabetologist, a gastroenterologist, a respiratory physician. It really is up to chance. And then we throw into the mix that you've got 4 different types. They have different treatments and they have different prognoses. And we're all in a bit of a pickle as to what we're going to do about this. Yeah, I think we can all agree. So heart failure with reduced ejection fraction. When I talk about this, you can have right-sided and left-sided of this, so right ventricle or left ventricle. And the risk factors for this is ischemic heart disease, far and away. You guys know this. We are PCIing more and more people than ever. And when you have a heart attack, there is dead tissue there that is non-recoverable. We do PCI to recover what we call the penumbra. It's a very good word. I love this word. And essentially it means the tissue that's not dead yet, but will be if we don't do anything. And it's usually double the size of the tissue that's already dead. And what we don't tell patients is about in 10, 15, 20 years, they will develop heart failure. We just have to give them time. But we're PCIing patients in their 60s, their 70s, their 80s, which means they're going to present later and later with their heart failure. Obviously, if you're diabetic with hypertension and you smoke, that's also not a good combination. So, treatment. This is to do with what we used to call LVSD. So this is left ventricular reduced ejection fraction heart failure. There is no real treatment for right ventricular systolic dysfunction. I think that's often something that we get confused as you know, non-heart failure specialists, is often we treat right ventricular squeeze problems the same as we would left, and actually the evidence base just simply isn't there. So when we talk about heart failure with reduced ejection fraction, it's a long-winded way of basically saying your heart does not squeeze. It's a pump, it squeezes and relaxes, it's not squeezing. The main treatment is to try and prevent your heart having remodeling, which is scarring and changes in the muscle that the heart tries to do in the early stages of having a heart attack to try and help you limp along, but actually longer term side effects are really detrimental. So the main three ones are the ones you all come across pretty much daily, which are beta blockers, ACE inhibitors, and whatever everyone else calls potassium sparing diuretics, but because I live in cardiology land, we call MRAs. Don't worry, it's the same stuff. So the first thing you've got to know, the ones that have evidence base are bisoprolol, carvedilol, and nebivolol. There is absolutely no evidence base for atenolol, though it does get used a lot. In my mind, it is the equivalent of Primark of beta blockade. Okay, it's cheap, it's cheerful, it's not going to last very long, and actually they often use it in trials very much as placebo if they're looking at it. So atenolol doesn't help in this type of heart failure. Carvedilol you may come across, but I don't tend to use it because it's expensive. Okay, and no one knows the dose. That's the truth of the matter. I'm a pragmatist, I live in the real world. No one knows the dose of carvedilol. It's different whatever age you are, what you're treating, all this kind of stuff. Bisoprolol, it's cheap, it works, everyone knows the dose, they know the side effects, and they feel happy up and down titrating it. I'm happy. Ramipril and enalapril are the next one. There is some evidence base for Catepril. Enalapril is actually better for older patients, and it's now come down in price, so it's the same as Ramipril. And actually, though this is for chronic heart failure, ACE inhibitors do help with pulmonary hypertension acutely. So you can use them in the acute setting if someone's got pleural effusions, really edematous, give them a bit of ACE inhibitor. There is actual proven benefit. It helps reduce pulmonary edema quicker. And then the third one's a spironolactone and a eplerenone. You can tell when someone's seen a cardiologist, they're on a eplerenone. It is 3 times the price of Spiro. It's a very expensive way of doing it. Spironolactone works very well. It helps with prognosis. It also is a very mild diuretic, and we generally give 12.5 to start off with. And it can be very helpful and synergistic with furosemide in certain scenarios. And when we talk about these drugs being chronically helpful in heart failure, so beta blockade in heart failure with reduced ejection fraction of LVSD subtype, we're talking about 30% increase in prognosis. Ramipril is about 25 and spironolactone is about 12.5. That's better than most chemotherapies. And when you look back at the data, heart failure with reduced ejection fraction used to have a 50% mortality a year. So we're not talking small things here. These work very well. And we also have at the bottom a CRTD, CRTP, which are actual functional things. And I'll come on to some pointers about that when we get there. But you may notice there's some new drugs on the block that are filtering down onto the ward patients. And the first one is something called Entresto, or if you really want to know what its actual components are, it's salcubitril valsartan, hence why everyone calls it Entresto. It's a compound drug that is probably going to replace ACE inhibitors long term. So you will start to see heart failure patients on it. It essentially has the same side effects as ACE inhibitors. So it causes acute kidney injury, postural hypotension. It's a compound drug and it's given twice a day. You can't halve the dose. You can't reduce it to once a day. That's how it works. So if you're going to need to reduce it or stop it, you really should stop it and get the heart failure team involved. Also be aware it's about £300 a month. Okay, so it's a very expensive drug. It's cardiology only at the moment, but we will start to see it filter through, particularly in the 50s and 60-year-olds as they get older. It's not really being used a lot in the frail elderly because they just can't tolerate it because of its side effects. So just to be aware if you do see this drug. The other one is dapagliflozin and empagliflozin. They fit in there in the pathway. These are SGLT2 inhibitors. Yes, they do make these really, really snappy and easy to remember. Not. All you need to know about these are diabetic drugs that help your kidneys pee out glucose, sugar. Why they work in heart failure, we have no idea, but they seem to. They reduce admission to hospital by 40%. They reduce mortality from heart failure by about the same amount. And we do know that they also have a really big impact on renal function in these patients. Okay, so they can actually make somebody who's in cardiac renal failure better. So they are good drugs, but they are diabetic drugs, but they're also licensed for patients who have heart failure who don't have diabetes. So you will start to see patients on diabetic drugs like this who have heart failure but are not diabetic. We haven't gone mad. This is actually licensed. There are 2 side effects that you need to know about these drugs, and you may start to see this on the ward. So because you're weeing out a lot more glucose, a lot more sugar, it does predispose you to having UTIs, because as you can imagine, bacteria love the fact you have sugary urine, and also thrush. But there's also a theoretical risk of someone getting DKA. We have not seen it in heart failure patients that don't have diabetes at the moment, but we have seen a couple in heart failure patients that do. So if you do see somebody on these drugs and you think they've got problems with their blood sugar, either in DKA, stop it. It might be this that's causing it. The other thing is with these drugs, if they're sick, if they're septic, if they've come in with a PE or a heart attack, stop this. It's the type of drug that should have a sick day rule. But some of the patients, we've all met them, continually take them, even though they're sick. These drugs, they should stop them if they are sick, because the risk of all these things happening, UTIs, DKA, increases when they're unwell. So they should be stopping this drug when they're unwell. So CRTDs and CRTPs, you may have come across it. This is what one looks like. It's actually a defib, and you can spot these a mile off. They have 3 leads. They have an RA lead, an LV lead, and this is an ICD lead. You may be able to tell the ICD lead's really thick because it's going to shock somebody. It needs to be thick. The important thing is it stands for cardiac resynchronization therapy. Patients who have these have severe heart failure and are optimized on medical treatment, so that you know they have to have quite a lot of symptoms to have one of these in. They often tell you they've got a pacemaker or a defib, but it's actually one of these. So please do check if you look at the x-ray, does it look like one of these? The boxes are usually bigger, it lies lower. And the reason I'm putting this up is for practical reasons. So these are being used more and more often, and they are very, very helpful and improve prognosis and symptoms in patients with severe heart failure of LVSD subtype. I heavily emphasize that. And the issue is that when somebody becomes palliative or someone is dying with this therapy, it's there to increase your stroke volume in a nutshell, to try and help your heart pump better. But if you have a PACE, a CRTP, or a CRTD, they both pace. One defibs and paces, the other one just paces. But if you have someone who's dying with one of these in, please don't put a magnet over it if they've got a defib in. Why? Putting magnets over things switches things back to factory settings. So if it's a defib, it won't defib, but it also won't pace. And when heart failure patients are palliative with one of these in, they are usually dependent on pacing. So they are paced 80 to 90% of the time. You put a magnet over one of these, you will switch it off and they will die quite quickly usually. So my plea is get an physiologist, I can't say that word, out to switch off the defib function only. In STH at the Northern, there is a 24-hour, 7-day-a-week service. You just ring them up, you tell them what you want doing, you consent the patient, they come in, they switch it off. Ideally, these decisions should be made 9 to 5, but that service is available. And so if you do have someone dying with one of these in, that is the preferred mode, because obviously if they're not paced, that's going to cause them quite a lot of symptoms at the end of their life, which is not what we want. And of course, we don't want the defib going off either. Okay. So HFpEF, this is my bread and butter, this one. So if HFrEF is a squeeze problem, HFpEF is a stiffness problem. I will explain that later. The risk factors are getting older, and I'm really sorry, ladies, being a woman increases your risk. Having high blood pressure is also one of the risks, and having something called cardiac amyloid. I've put this in because when I was a medical student, we got told cardiac amyloid's a palliative condition, don't worry about it, so they'll be dead before you even consider treatment, because it was that bad. We do have treatments now. It's about £500,000. You do have to go down to the centre in London to get it done, so it's a big ordeal. But the important reason why, if you see someone with HFpEF and there is mention of query amyloid, particularly in elderly patients that I'm mentioning this, is because about 5% of those will have an undiagnosed hematological malignancy. So myeloma, leukemia, chronic lymphoma, which is very common in elderly patients. And actually, if you do see it, doing a serum electrophoresis or just doing a full blood count, probably worth doing, just to make sure they don't have cancer, because obviously that needs treating, probably a little bit more urgently than their heart failure, to be honest. Okay, so HFpEF, I'm going to try and explain this to you, and don't panic. It is all about the E's, and when you look at echoes, it's this box here. Yes, don't panic. I know there's a lot of numbers. I know it's the bit in the report everyone ignores, yeah, because they go to the report, because that's a bit scary. So I'm going to try and explain it, and then I'll tell you how I explain it to patients, and we'll get there. So an E to A ratio is what we used to use, but I'm going to use it because it's a lot easier to explain than what an E to E prime is, which is what we use now. So an E to E prime is the E/E comma thing, and the E to A ratio is what we used to use, and I'll explain why we don't use it in a minute. So an E to A ratio is the ratio of peak velocity, so how fast the blood is flowing between early diastole, so everything's just contracted and is about to relax, and then A is when the atria contract and the ventricles are fully relaxed. So the blood, just as everything's fully contracted and is about to relax, should be faster than the blood when the ventricle's fully relaxed and the atria is just gently contracting and plopping the blood into the ventricle. So E should be bigger than A. If A is bigger than E, problem. We use the E to E prime because we used to measure A and E like miles apart in the heart, and now we measure it across the mitral valve because it's more accurate, particularly in patients with atrial fibrillation. So that's what we're talking about. And even if you can't remember that, this is the take-home message. An E to E prime less than 8 is normal. An E to E prime more than 15 is stiff. Okay, but Fiona, 8 and 15 are nowhere near each other. No, they're not. So I have some home truths to tell you. So you know the echocardiograms that we do and they spit out numbers at you? There is about 20% variability between if I did it, you did it, and someone else did it. So there is variability in the test, a lot more than a CT scan. And also we don't know what these numbers mean, whether they're just gradually aging and this is just a normal factor. So these are the numbers that we've attributed. The other thing to bear in mind with HFpEF patients is 2/3 of them will be in atrial fibrillation, whether you know it or not, because of part of this process. And remember, they tolerate being in AF with a fast ventricular response poorly. Why? I will tell you why. So normally when your heart is fully relaxed and the atria are just gently squeezing the blood in, your heart doesn't pump like this or like this or like this. It does like a wringing the dishcloth motion, okay? That's what I call it. So when it relaxes, it's a very active process and actually causes a negative pressure within the left ventricle. So the left ventricle, it's really muscular, should suck the blood from the left atria to the left ventricle. So the left atria really doesn't have to do a lot of work. It should just plop the blood in, really. I know that's a horrible word, but you get the picture. Should plop it in. And actually, shouldn't do a lot of work. But when your heart is stiff, your left ventricle doesn't have that negative pressure. So the left atrium has to work harder. And actually, it's not meant to do that. It's not very muscular. So when everything's going like the clappers with AF, say your heart rate's 110, everything's not working and the LA just can't keep up. It's not meant to do that. So you often find if these patients become septic, they drop their blood pressure a lot sooner than you think they should. And actually the key in this is rate control in their AF. Their blood pressure will come up beautifully. Okay. So how do I explain this to patients? Because I can already see there's some knitting signs here. But we'll go through the old echo I showed you earlier. And if you look in that box, you can see the E to E prime average is 22.75. This woman's got HFpEF, and she was a woman. They always are, majoritively. Okay, so how do I explain this to patients? Because most doctors don't really understand this, I can probably attest to. So in my head, I'm going to give you a mental image. A heart, when it's relaxed, should be like a 10p bag for life from Tesco, Sainsbury's, Moribog's, pick your supermarket. When you're filling it, it's flexible, it's dynamic, it molds to the shape, yeah, and it has that bounce, that recoil. Instead of being a plastic bag, their heart is like a plastic bucket. The sides are stiff, it can still fill, but the top value is the top value. It can't adapt to what it needs to. And classically, these patients, when they're walking upstairs, walking up inclines, really struggle because the heart just cannot increase its stroke volume. It just can't increase it. It just can't do it because the walls are stiff. So hopefully that will stick in your mind. Plastic bucket, not plastic bag. I know, not high tech, but it works for me. And feel free to steal that. Treatment of HFpEF. We are really scuppered for this. So these are all the major trials. And as you can see, I've highlighted the overall results for all of these trials are that none of it is beneficial. So in HFpEF, there is only really one treatment currently, and that's furosemide. You can add in spironolactone because there was a very small study that showed it reduced the risk of cardiac death, but only at 12.5 milligrams once daily. That's it. And actually, there's not a lot else that's on the market at the moment. So these patients are in real trouble and still have about a 50% mortality a year. So these patients were really struggling. And in NICE, there's pages about LVSD, pages and pages and pages, and about a paragraph on HFpEF, which says control the risk factors, which is control the blood pressure, treat hematological malignancy. We can do nothing about age or gender. So it really is tricky. Though interestingly, the empagliflozin I mentioned earlier on has just released some data from the EMPEROR trial a month ago, and it does look like that may be a potential treatment for this that's coming in the next year or so, but it isn't licensed yet. But you may start to see that creeping into this treatment as well. So we've got all of this, and if I haven't already boiled your brain, I'm sorry. And then we throw in the fact that you have elderly patients and they have postural hypotension, hyponatremia, polypharmacy, comorbidity, side effects, compliance issue, falls risk, incontinence problems. Yeah, welcome to my world. So general practical pointers about these patients. Be sensible. You can't fix everything. And talk to them because you're going to have to sacrifice something eventually. And we're going to sacrifice something, and for me, it's going to be their renal function, because A and B are A and B in your ALS for a reason. If they don't have an airway and they can't breathe, they're going to die. And unfortunately, renal failure is not even in that algorithm, is it? It's kind of fallen off the end. And I will, in NICE, recommend you can sacrifice 30% of their renal function from their baseline. I would even go as far as 50. So if their creatinine is 200, I will let it rise to 300. Yes, I know, I just said that. If their potassium's okay, their sodium's okay, they're not falling over left, right and centre, all these kinds of things. But they have to sacrifice something frequently, okay? And we're really bad at prognosticating these patients. We're appalling because they're not like cancer patients where they just gradually get sick. They do these oscillations. You've all seen those patients. They bounce in and out like ping pong balls. And then they get worse. They go home, they come back and you're like, ooh, okay. You were very sick the last time I saw you, but you're okay now. And then they get sick and they come back and they do this sort of oscillation. And the other thing to be aware of is that in frail elderly patients, it's a palliative diagnosis, and we don't often treat it like one. We often treat heart failure like diabetes, but in frail elderly patients, it's palliative. So what's a magic score? Yes, it is 2 Gs, 1 C. I didn't invent it. They thought it was cool. This is what it looks like, and it is available on MedCalc if you want it. And it will give you a 1-year and a 3-year prognosis for your patient. And that, I think, is very useful for me to start off those conversations, particularly around DLARs and particularly around advanced care planning. Because frequently patients with heart failure, we have about a year's time from when they first are admitted to hospital to start the process of planning their future, because we know they're generally going to decline after that. That is the turning point in most heart failure patients' journey, that first admission to hospital. And this actually, I think, helps solidify it in my brain, actually, should we be having those chats right now? And often the answer is yes. So we've got some scenarios here, and this is a classic. They come in acute kidney injury, yeah? Heart failure patient, known heart failure patient, they're in AKI. Please assess their fluid balance. You guys are very good at doing this. If they are full of fluid and they're leaking fluid from the legs, don't give fluid. It is the bane of my existence to see a heart failure patient that has edema up to their abdomen and they're hooked up to a drip. They have AKI because their heart is struggling with the amount of fluid and they're not perfusing their kidneys. It's not reaching there. Kidneys like fluid, but from the artery, not just basting in it. And actually what we need to do is what the cardiologists call diuresing through the AKI. So actually what they need a diuresis to get rid of some of that excess fluid so the heart can pump better, so the actual blood pressure and the arterial supply to the kidneys is better. And actually what you'll find is their renal function will improve, not decrease. If they are a tad hypovolemic, a tad on the dry side, don't do anything. Is generally what I would say. Remember that 30 to 50%. If they're fine and they have no side effects and they're walking around, their potassium's fine, their sodium's fine. If it's within 30 to 50%, chill, is what I would say. If it is a bit more than that, a bit more than you're happy with, don't stop all the diuretics or all that really good treatment that they are on, specifically for LVSD patients. We said it's prognostically more beneficial than most chemotherapies. Dial it back, reduce it, review it. Often what I see is people get into panic mode with these patients of stop everything, put some IV fluid up, and then in about 4 days' time you come back and they look like the Michelin man because they're full of fluid. And then we diurese them when we overshoot it, and then we fill them back up with fluid. Be cautious with these patients. So with these patients, if it is a bit more than what you are happy with, what's acceptable, dial it back and get them to drink more. I don't know why we hook people up to drips when they have a working mouth and they're able to drink. Most patients, when you put a jug of water in front of them and say, drink 1.5 of these and it will help you go home, generally works in my experience. And if they are someone who's frail with dementia that has issues drinking, you need to actually, sometimes I've even prescribed a drink an hour. So someone has to go and give it. And it is a lot less delirium inducing than hooking someone up to a drip. The key here is also other medications. Review those if they are truly an AKI. If they are really, really crispy, if they're really, really dry, fine, okay, I'm with you. Stop the diuretics, stop the nephrotoxics. Yes, they can have a bit of fluid, and I'll explain how much fluid in a minute. A bit of fluid, but make sure that there's a review date on that. I often see, particularly if we're going into a long bank holiday weekend, we've prescribed all the fluid, we've stopped all the diuretics, and by Monday, things have not gone according to plan. The other medications that you really need to bear in mind, particularly as these are often vasculopath, things like metformin, antibiotics, Doltapar, in all of these, if their EGFR or their creatinine clearance has gone off, we really do need to do a medication review because that often causes more problems. I have had a patient with heart failure go into lactic acidosis because someone hadn't reviewed the metformin. I've also had a few other patients go deaf because we hadn't twigged and they were on gentamicin. They're not decompensated at all, but they need a bit of fluid, or they are very crispy. Bear this in mind, very dry, sorry. All fluids should be prescribed according to weight. You guys know this. Some of my colleagues do not. That a 33 kilo frail older woman should need the same amount of fluid as a 250 kilo rugby playing 6'4" man is bizarre, and I am still frightened when I hear the phrase too salty, one sweet, too salty bandied around like it's actual medical acumen. It's hearsay and should not be adhered to at all. It should be 30 mils per kg for maintenance. So if you're a 33 kilo woman, that is 800 mils. It's not a litre, it's 800 mils. We often really overshoot what people need in terms of fluid. And the other thing is if they are very obese, that also works because they have lots of insensible losses because of their surface area. Also remember, normal saline and Hartmann's contain far more sodium than you ever need in life. And actually we should really be prescribing half strength. If we don't prescribe it, it doesn't get stocked. And my other pet hate in life is IV freezamide in one arm, IV fluid in another. Pointless, pointless, pointless. If somebody is dry, they don't need the freezamide. If somebody is overloaded, they don't need the fluid. If they're just nil by mouth overnight, people don't need fluid overnight. They don't normally drink. I think we often get carried away a little bit. The other is true for bumetanide. Just be aware. Please don't do the IV fluid diuretic combo. It really isn't helpful for your patients. You're just pouring in fluid to wee it all out again. It's not helpful. So they come in and their blood pressure's low, or they've fallen over and they've got postural hypotension. So remember, low blood pressure doesn't always cause an issue. A lot of heart failure patients, as it progresses, will have low blood pressure because the heart can't actually squeeze enough to make a big blood pressure. And they can be walking around quite happily with blood pressures of 80 systolic. My resting blood pressure is 75 systolic. My BP frightens my GP quite frequently. I'm fine. It doesn't need to go far. I'm 5'2". It goes up, it goes down, and we're happy. And a lot of the heart failure patients are the same. So don't stop all the drugs if they're fine, if they haven't got issues. High blood pressure also doesn't always need treating. And I think we get carried away here as well, particularly in the middle of the night when someone does their blood pressure at 2 a.m. My blood pressure will be high, my adrenaline will be pumping. It's a trend. And actually, when we do measure high blood pressure, we really should be doing a lying and standing because it's not infrequent for a lot of frail elderly patients to have resting hypertension, but have significant drops when they stand up. The other thing to bear in mind is patients with dementia, 30% of them will get postural hypotension as part of their neurological deficit from their dementia. So it's really common. It's also very common in Parkinson's patients and in type 2 diabetics. They get peripheral neuropathy and central autonomic neuropathy, which is what controls your blood pressure. But what happens if they truly do have postural hypotension and they're symptomatic and they're falling over left, right and centre? So if they've got LVSD and they're on bisoprolol, ACE inhibitors, spironolactone, I have two rules. Divide and conquer. If all else fails, keep bisoprolol 1.25, ditch the rest. Okay, so when I say divide and conquer, split the doses up. Again, we have very concrete thinking about this in medicine. Everyone should have their tablets at either morning or nighttime or the middle of the day, yeah? Because that's convenient for us in hospital. But actually, giving someone all their medication that lowers their blood pressure first thing in the morning before they have their breakfast is really, we're asking for trouble here, aren't we? So splitting things up. So if they need, say, 3.75 of bisoprolol, I have one patient that has 1.25 in the morning, 1.25 at midday, and 1.25 at 5 o'clock. I then give her 1.25 of ramipril before she goes to bed. And then I obviously give her a diuretic in the morning. But splitting it up, dividing it, actually, could we keep a bit, but just reduce it? If it really doesn't work, then keeping bisoprolol, even 1.25 is helpful. I generally would put it later on in the day, even nighttime, but sometimes that you can't even manage that, and that's okay. But you do need to talk to your patient about the fact that we're probably entering end stage because we can't treat it and things are going to get worse. HFpEF, you really are going to struggle here because we said the only treatment is furosemide, and if we stop that, they're going to fill with fluid. This is a palliative discussion we need. And BP boosting drugs. Anyone know any of those off the top of their heads? BP boosting drugs you've come across? They're a bad idea in heart failure. So I will put you out of your misery. There's 3. Fludrocortisone is a mineral corticoid often used in elderly patients. It works by holding on to fluid and salt. Bad idea in heart failure patients. Please don't ever prescribe furosemide and that together. It's a really bad idea. Midodrine vasoconstricts you peripherally, and these are vascular paths, so generally people start to lose toes and fingers when you do that. And pyridostigmine is used off license, and I don't feel should ever be used for this indication. So if you do see that, be careful. So yeah, postural hypertension, hyponatremia, really, really common. If it's chronic, don't really panic if they're okay. Check all the other drugs. So frequently these patients are on amitriptyline, PPI. Stop those first. They're less prognostically beneficial than what we're giving them. Always assess their fluid status. Frequently people are overloaded and actually it's dilutional. You need to diurese them and actually their sodium will come back up. Please don't do osmolality if they're on a diuretic. The test will prove they're on a diuretic and you've wasted about 100 quid to prove they're on a diuretic. Do your treatment, do the protocol as per NICE, which is assess fluids balance and go through things. And if things don't improve, then do an osmolality. But even though I said don't worry, hyponatremia in whatever context, whether it's medication related, sepsis related, heart failure related, offers a very poor prognosis, both mortality wise and morbidity wise. And actually, if you do see it in your patients, we probably should be discussing with them about the fact that things are going to struggle. I have a patient on my books currently who has a resting sodium of 120. She has HFpEF. Someone gave her furosemide 20 milligrams. She ended up in a hospital near here fitting with a sodium of 115. She can't have any treatment. She did get better. She went home. And actually, when she came to my clinic, we had a big, long discussion, and she now has a DNAR and an advanced care plan where she avoids the hospital because actually we make her so much more worse than what she is at the moment. And she now has a lasting power of attorney. We've got that sorted out for her and all these types of things. So sometimes tablets are not the best solution to a problem. So we've got a case here, and I would love it if you guys would either talk at me or type in the chat box. So you're bleak to see an outlying patient on a surgical ward. She's an 8-year-old woman admitted for a week after having cellulitis in her left leg. She has a past history of congestive cardiac failure, hypertension, type 2 diabetes with end organ damage, recurrent cellulitis because she's got diabetic ulcers. She's got a clinical frailty scale of 6, has 3 times a day carers, and she walks with a Zimmer frame. You're asked to see her as she's feeling very short of breath and feels awful. Her news too is as follows, and her SATs are 92% on air, her resp rate is 25, her blood pressure is 90/60, her heart rate's 120, and her temperature is 37.2. What are you going to do? Anybody?
Carry out ABCD first, assessor.
Lovely, like that one. Anyone else? Anything else? I might give you some more information before then. I like the ABCDE approach.
I'd want to know what's changed, whether she's been going quickly for a while, whether her heart's regular, if she's in a funny rhythm, and whether her blood pressure's moved at all. Like, is this unusual for her?
Fabulous. I like that answer too. So you arrive because you haven't got that information. The person on the other end doesn't know, and she looks out of breath. She's on IV flucloxacillin running, as well as a litre of IV normal saline. She's had 4 litres of IV fluids in the last 24 hours, and she weighs 35 kilos. She has pitting edema to her thighs, a JVP of 4 centimetres. She was admitted on bumetanide 3 milligrams and spironolactone 12.5 milligrams, both which have been stopped. Her creatinine's 200, her baseline's 150. She's an AF with a fast ventricular response. She's not catheterised, and her blood pressure normally runs at about 120 systolic.
She's pretty wet.
Yeah, what's happened here?
Stop. Would you consider stopping the fluids because she's gone into heart failure?
Yeah, definitely. She doesn't need them.
And IV fluids, yeah.
Okay, so she's come in with cellulitis. Was she septic if she had a blood pressure of 120 when she came in?
Unlikely.
Yeah, so what happened, do you think? And we see this quite frequently.
It looks like they've just gone gung-ho with all the fluids, 4 litres for a weight of 35 kilograms.
Yeah, that's baby bathwater territory, isn't it? Okay, but what do you think happened? What's the key part of this? And I see this quite frequently.
Presumably they've looked
Her
at
creatinine went up.
Her creatinine went up, so someone got worried. Yeah. What else happened? She got outlined. And we know she's a frail older adult that has 3 times a day carers, and frequently these are carers that help her eat and drink. And so what probably happened is they got a bit worried about her eating and her drinking, so we strung her up to an IV line. Yeah. So yeah, that frequently happens, and unfortunately we've gone a bit to the other way. So how are you going to treat this lady? What are you going to do other than stopping the fluids? What are you going to do?
I think I'd start off with trying to control the heart rate first.
Ooh, okay. What are you going to give?
Bisoprolol.
You could do. Has anyone else got anything different? Anybody else might choose something different?
I think I might, digoxin. I might consider it.
Okay, why are you thinking digoxin? Why are we thinking bisoprolol? Can someone chat to me about that?
She's an elderly lady. She's got heart failure, and digoxin works better in elderly people with heart failure to offload her.
So it doesn't offload, but it can definitely help.
Doesn't dig help preserve the blood pressure or have less effect on the blood pressure?
Yeah, you got it. Yeah. So her blood pressure is 90. So some people get a bit scared about giving bisoprolol because it will drop the blood pressure a little bit initially. So yeah, it would preserve the blood pressure. But what's a bit of a concern about digoxin?
Toxicity.
Yeah. So what I would say is that often you get taught, don't give bisoprolol in acute heart failure, it can all make it worse. Not if she's going like the clappers, you need to control it, I agree. So it really is a judgment call here, whether you give digoxin or bisoprolol, but she does need rate control. In her case, I might give her a little bit of bisoprolol and try and bring it down a bit, okay? My concern would be is if she needs regular rate control, which she probably will do at some point, digoxin is going to be a problem for her because of toxicity. So say we give her a little bit of bisoprolol and it brings down her heart rate to say about 100, we feel a bit happier. Her blood pressure is now also about 100. What are we going to do next? What are we going to give her?
Probably some diuretics.
How and how much?
I wouldn't potentially just be a bit cautious and not give IV to start off with. Maybe just give some stat oral.
So oral's going to work in about 40 minutes time, and a SAT's a 92%. I think we probably need something a bit quicker. But what's your worry about IV? Why are you concerned about IV?
Just that she's already a little bit dry. I suppose also though, then we could catheterize her, monitor her fluid output.
You could. I'm not a fan of catheters there.
I suppose you could start off low and just give her 20 of, maybe not furosemide.
You could. So how much furosemide equivalency is she on normally? Does anyone know the equivalent dose? So she's on 3 milligrams of bumetanide. How much is that in terms of furosemide normally? Does anyone know?
Is it 80 or 120? No, hold on, I'll let you.
So 1 milligram of bumetanide is the equivalent of 40 milligrams of furosemide.
Yeah.
Okay, so she is normally on 120 milligrams equivalent. So 20 is probably not going to do much for this lady, I'm not going to lie. So from my perspective, I think she does need a bit of furosemide. Yes, I know we've just got her blood pressure back, but we do need to give it. But we can give her a loading dose. And then how else we might continue the diuresis, because she's normally on 120 milligrams. It's a fair old whack. How else? Because we tend to give it as shots, but how else could we give her furosemide?
Continuous infusion?
Yeah, these are my favourite things, particularly with people with very dicey blood pressures. So you can put 120 in an infusion and infuse it. At this point, this lady's more than likely got an edematous gut. She's not going to absorb anything orally. And yes, she's got a creatinine of 200, but this is probably hypoperfusion because actually she's overloaded. Okay, fantastic. Any other questions about this case? I have a few more if that's okay. Yeah, 24-hour infusion said no, thank you. So case number 2, you're called to see a patient on the care of the elderly ward with a blood pressure of 80/50 and a heart rate of 50. She's 96 and she's been admitted with a worsening leg swelling and a fall. She's got LVSD, we've gone more specific this time, type 2 diabetes and ischemic stroke. She's got breast cancer. She's had a hysterectomy. She's got hypertension, CKD, and she's also got dementia. Good. What are you going to do? What questions are you going to ask?
She all right?
She all right? Yeah, love that question. Yeah. Is she actually okay? What else? A, B, C, D, E. Yeah, fine.
Is there potentially a compliance issue with her medications as well?
Ooh, I like that question. Okay. Is she taking what we think she's taking? Okay. So on arrival, the patient's clearly confused. Okay. Her blood pressure is 80/50, her heart rate's 50, her temperature is 37, her saturations are 90% on 2 litres. Okay, and her respirate's 25. Her saturations have been low since admission, and so is her blood pressure. Her pitting edema to her sacrum. She has no catheter, but the nurses state she's not passed urine all day. Her bloods were taken earlier. I'm going to give you some more. Her creatinine is 350. Her urea is 22. Her sodium's 129. Her potassium's 3. She was on an IV furosemide infusion of 240 milligrams in 24 hours, but her weight hasn't improved. Neither has her renal functions or her oxygen saturations. What are you going to do?
Consider a bladder scan in her if she hasn't passed urine all day.
Okay, your bladder scanner, she has no urine in her bladder.
No.
What are you going to do?
Speak to renal.
Do you think
Give us
renal would be
fluid.
interested in a lady who has that many comorbidities? Probably
I suppose
not.
they might be able to offer a bit of advice.
They could do.
But
I think the advice would be what? What's your overwhelming feeling, given everything I've just told you?
We're not winning. She's
on her way out.
Yeah, she's palliative.
Hepatorenal. Yeah.
Yeah, she's got cardiac renal failure, and she's hyponatremic, and she's got multiple non-reversible comorbidities. She's dying. So actually, in this scenario, there's probably not a lot you can do. But what we do need to do, which this lady didn't have, is talk about death, dying, a DNAR, and palliative care. Because actually, that's probably going to be the best thing for her rather than more diuretics. I think we often get caught up in, let's just diurese and it will all be okay. The key thing here is actually the trust policy has actually changed. So you can give subcut furosemide now if someone's palliative, up to 120 milligrams. via a 24-hour infusion if we felt it is beneficial. But frequently the patients who are end stage are on more than that, and often I find morphine or oxycodone, particularly in these patients, are of most benefit because it takes your symptoms away. A lot better than subcut furosemide, because who knows when that hits a receptor when you've got that much fluid on board. So hopefully you found that interesting. You can now identify the type of heart failure and treat it. Be honest with the patients and families. You're gonna sacrifice something at some point. It's going to be the kidneys. And remember, in a lot of patients, it's a palliative condition, and we really are just preventing the inevitable. And often we need to have conversations rather than go a bit gung-ho with the treatment plans. So, has anybody got any questions, or have I bored you all?
No, it's been really good, thank you. Can I just ask,
Yep.
what is the accepted level of hyponatremia, so the sodium?
So it depends who you ask. So most people, including community, would say 127 is the cutoff. I frequently have patients who have lower sodiums. It's all about trends and how they are clinically. So if I have a lady in my clinic, as I said, who's got a sodium of 120, she's walking around, she's okay, she's fine. And she's had a sodium of 120 for nearly a year now. That's normal for her. And it's all about the shifts, always with electrolytes. It's never normally about the absolute number. Some people just run low or high, and 5% will be outside the standard deviation. It's about the pattern and how quickly we change things. So 127 is what GPs are advised needs admitting to hospital and investigating, but frequently with older patients, it is lower than that. So look at trends. Is it actually very much different? Has things changed? Is it 10 lower or higher than it was before? So it is very much about shifts and about other drugs as well. So yeah, it's about looking at the pattern more than an absolute number in my experience. Remember, this is from a geriatric patient perspective, because they frequently don't fit in the boxes that we assign them, just for fun. Any other questions at all? And it can be anything. There is no such thing as a silly question. I have been talking at you quite a lot. No.
In regards to the half dose of saline, so the 0.45%, would you sort of routinely prescribe that in patients that are quite elderly with normal saline, with normal sodiums?
So I frequently do, particularly in the low body weight ones, because there's far more sodium in normal saline than we actually give it credit for. And I've often seen, I'm sure you've seen it, it's just normal saline, normal saline, normal saline, normal saline, normal saline. Someone maybe thought about Dex, but it never got given normal saline, normal saline, normal saline. And actually, even the NICE guidance say we should be using half strength. We shouldn't be using normal saline anymore. Yes, I agree, it is cheap. It's about 20p a bag, and it is stocked on the wards. But if we don't prescribe the half strength, it won't get stocked. But we are really behind in terms of fluid prescribing, particularly the medics.
Thank you.
Anything else? Nope. And then I think we're done, if that's okay. I will stick around for another 5 minutes if anybody wants to ask a question that they don't want other people's to hear. That's absolutely fine. But thank you so much, guys, for joining me. I really enjoyed it.